Can you hear anybody? You. How do I know my screen? It's on. Yeah. Okay. How do I know if I'm being seen or not? All right. All set. Hello, everybody. It's Dr. Crosby. Just finished up with patients this afternoon. Started a little bit late, so I apologize. Thank you for registering for today's webinar. We have just kind of a broad review of foot and ankle injury that was summarized in kind of a short segment of slides and other procedures and things that we see on a common basis at OrthoSC in the foot and ankle department. Well, I'm not getting the next slide up, so how's that slide? Arrow right or left, it didn't work. There you go. So like we said, injury and treatment and some other common foot and ankle ailments. I'm a native of the region. I grew up in Georgetown, south of Myrtle Beach. I'm sure most know where this is. Went to undergraduate University of South Carolina and then on to work for a little bit, back to school in Miami, residency training in Florida and private practice back in Georgetown, started in 2004. And private practice merged twice to end up where we are right now with OrthoSC. And your provider of orthopedic care for this region. Most of what you see in front of you is where I spent my time. Again, in Columbia and back to Florida. I'm board certified in foot surgery as well as rear foot and reconstructive and ankle surgery, which is the second board certification that I've taken. Cover Conway and Market Commons, Myrtle's Inlet area primarily. And interests. I think these are some bullet points of things we'll kind of run through is Achilles tendon, acute foot and ankle issues, including fractures and dislocations, bunions, midfoot and hindfoot dislocations, complex fractures, arthroscopic cure of the ankle primarily, but also subtalar joint, elective surgery like bunions and hammer toes are listed up there as well. And then tendon, some tendon issues. Stress fractures are pretty common in the foot and ankle, and then so are orthotics and bracings that we use for an outside source. For orthotics. Objectives today is obviously if you know your anatomy, you can figure out what most of the issues are with your foot or ankle, the location, bone, tendon, or ligament that could be a problem, or a joint for that matter. Both non-surgical and surgical treatments. And then answer your questions if you have them at the end of this thing. Just a basic diagram. The foot's relatively complex with 33 joints, 28 bones, number of tendons, over 130 ligaments. Common fracture areas, it's got the red spot where the navicular is and the fifth metatarsal fracture. We see just about every kind of injury you could imagine with the foot and ankle here. The lateral ankles, excuse me, the lateral ankle for sprained ligaments, for example, or sprained ankles. Those are the three most common ligaments that are sprained. You'll see there anterior talofib ligament, calcaneal fib, and posterior talofib, but also you'll see in the middle a couple ligaments that stretch over The midfoot bifurcate and the metatarsal joint ligaments are also sprained. Some additional anatomy of the lower leg. Posterior muscle group or the superficial posterior muscle group that includes the gastroc large muscle to the excuse me, to the caudal surface, the dorsal portion of your leg before the knee. Is the, excuse me, is the gastroc. The plantaris, as well as the soleus, come together to form the Achilles tendon, and then you'll see the retinaculum as the posterior heel bone. Thank you. Maybe another one. I apologize. The Achilles tendon, the largest functioning tendon in a human body, the back of the ankle. Very powerful. That's why we can stand on toes with one leg. The two muscle groups that come together, the gastroc and soleus, to make the Achilles tendon. It is a very important muscle for activity, walking, running, or jumping. Achilles tendon overuse or stretching syndromes. Two types of Achilles tendonitis. Primarily is insertional, which means where it attaches to the posterior aspect of the heel bone called the calcaneus, which is the bottom one, and then the top non-insertional Achilles tendon, which is what we call the watershed area. It's an area of dysvascular region. There may be a minor strain or injury to the tendon where the fibers of the middle portion of the tendon can begin to have micro tears, and then it swells. You get through from tendonitis to tendinosis, and then a possible rupture from that region. Insertional Achilles tendonitis involves the lower portion where it attaches to the heel, which is a very similar. It can cause micro tears and lead to additional injury and or rupture of that location as well. Achilles tendon problems you'll see here. The area of the watershed on the left diagram, where the arrow is in the mid substance, and you'll see where the tiny tears can occur to the middle right as you come down, and then the lower where you have an and a complete Achilles rupture of that region. Symptoms typically are there's minor irritation prior to the injury of a rupture. These patients usually have some sort of irritation or twist that causes some irritation of the tendon. There's some sort of snapping or popping sounds that can be there. At one moment, you may have an inability to push off because the tendon can rupture. Most patients complain of being hit in the back of the leg with an object, a ball or a stick, something that see the sensation feels like something hitting you in the back of the leg, as we will see it. Diagnosis and treatments options. From our standpoint, is just getting visible to a foot and ankle specialist or guys that are in sports medicine to assess the tear. You don't always have to have a MRI or X-ray. X-rays help in case the avulsion occurs at the heel bone level. And there's two options behind the philosophy of treatment. Depends on activity levels, age, comorbidities, weight, et cetera, that we usually surgically operate on these to keep the maintenance of the tendon intact, function high, and get you back to the activities that you love. Surgical repair is usually done within 7 to 10 days post rupture. That way we can get supportive structure back together. If it's too far post-surgery, for example, if it's a month, a lot of times this tendon's already scarred down. You have no options other than a conservative rehabilitation. Once a repair is done, the two concepts of surgical repair with the appropriate suture called fiber wire or additional complex repair, including graft, allows the tendon to be healed back to normal, let's say somewhat of a normal process, but the reoccurrence rate is significantly improved by repair. That's one of the biggest issues with athletes. So we repair them and get them back to normal function, but also the weekend warrior, these active patients that we see play racquetball or pickleball, like to walk or bike or stay active, even in older age. From a non-operative treatment, again, comorbidities may consist with peripheral vascular disease, diabetes, recurrent rupture, and some other issues that prevent us from doing that, or length of time before identifying the rupture before the repair. The non-operative technique is with a plantar flex caster boot with a heel lift. It takes approximately 8 weeks. Again, the problem with this, I thought we use the word problem lightly, but the possible complications with non-operative care or re-rupture risk. Secondary kind of deformity of the region where the Achilles is what's called Haglund's. It's a bone spurring of the posterior aspect of the heel. It either can be anterior to the tendon or in the tendon itself. Most patients will notice a prominence or enlargement of the posterior aspect of the heel, irritated by shoe wear or bumping it against things like a little countertop or edge of a chair. Also can cause Achilles tendonitis over the top of it. These conditions may be surgical or conservative as well. You see the bump here. Patients usually have an x-ray taken and see how large the spur is, if at all there is a spur. Sometimes you have complete tendinosis of the region where the tendon is only swollen over the spur. The suggested treatments of the spur is much larger. The again, comorbidities and age associated with activity. The spur resection is something suggested with younger age if the spur is quite developed. If you have first time occurrence, usually we're able to do a minor lift, physical therapy, potential PRP injections, boot treatments, et cetera, for non-operative treatment. If there is an operation that's required, patient have reoccurrence Achilles tendinosis with the spurring and the spur is resected. I use a technique that very similar to rotator cuff repair, where that's secured very strongly to the posterior aspect of the heel to remove the spur from the back of the heel. It's called a speed bridge and attaches the heel cord to the heel after the spur resection. 3 weeks non-weight bearing recovery, and then in a boot with a heel wedge for approximately 5 additional weeks, and then physical therapy and back out into shoes. Additional recovery time is, of course, going to be needed to get through all that. Bunion deformities. See all different levels and sizes of bunion changes, et cetera. We'll have some modifications that we adjust through on how we assess these, but both are conservative and surgical. Conservatively, I'll discuss in a moment. Structural deformities of the bones where the first metatarsal and the second metatarsal protrudes. It's actually a movement of the first metatarsal to the medial side of your foot, which is towards your belly button. The hallux is tied tightly to the lateral side through a tendon called the adductor tendon, and it pulls the hallux to the left or towards the second toe. It affects the joint at that location. And so patients start to have pain on both sides of that joint. If it's consistently painful in or out of shoes, usually patients will be we'll make an appointment. Evaluate where the x-ray progression is. Conservatively, we ice and heat an occasional injectable for relief of symptoms. Spacers and splints can be utilized, but they are not corrective procedures. They can temporarily relieve the symptom, but as soon as you take the brace off, the progressive deformity will reoccur. But those are some conservative treatments, including wider shoes and, of course, sandals and flip-flops assist with the symptoms. Surgically, if the symptoms persist, we do surgical repair of the first metatarsal bunion. You'll see here on the top picture, patients, we've got an angle between the two yellow lines that consist with what's called an intermetatarsal angle. The two bones beneath that region are called sesamoids. They're similar to your kneecap. They will float. They glide left and right under the first metatarsal. In order to have a correct treatment, you've got to slide the first metatarsal or move the angle to reduce the angle between the yellow lines. As you can see, the bottom radiograph shows them parallel, and the two bones underneath are back under the metatarsal head. Temporary fixation can be used in any of these cases. You can see a small K-wire inserted in the bottom radiograph. Small screws are common K-wires or even staples. Severe deformities, like we'd said, usually create much larger prominence, a much higher IM angle. So for example, the top X-ray would be much wider. The yellow lines at the top view would be much wider. There can be crossover toes where the toes are straddled over the top of the big toe or beneath. Usually you see that with a much higher deformity. Bones are shifting apart. As you can see on the left side, sesamoids are distracted into the inner space and enable to reduce or get those lines parallel. We do osteotomies or cut the bone in different locations for the most appropriate treatment for the patient. Some hardware, again, is utilized to stabilize that in place. Recovery for both of these types of procedures, both distal, this procedure on the bottom left, and then on the right, have some variances in length of time to recovery, and every patient's slightly different. The further towards the toes, for example, on the bottom left, is a 4 to 6 week recovery. Same for the right. However, there's a non-weight-bearing status included. Hammer toes we see as an elective as well, similar to bunions, may be painful, create calluses or ulcerative lesions at the top or distal portion of the toe. They're caused by a change in muscle strength, the intrinsic muscle atrophy that can happen over time. Again, can be genetic, can be acquired if you tear a muscle or tear a tendon. They may cause pain, like we had said, and usually it's got an associated skin change from a pressure point. You'll see different shapes of toes. For example, only the third toe of the top left becomes an underlapping toe. Looks like all four on the bottom left, and then a little slightly transverse deviation, plane deformity of the bottom right. And so here we map out how to reduce those consistently and reduce those angles and get those straightened. I might include on this particular film lots of different types of deformities of the toes. We use different types of little implants, which could include little bone segments that are used as stabilizers or K-wires for that matter. And in today's world, you'll have multiple options for fixation. Liz Frank's one of the more devastating injuries to the foot, caused by something as simple as microtrauma or slip and fall, or it could be as much as a car accident or falling off of a bicycle, motorcycle, or a horse, for example. It's a very powerful ligament at the base of the second metatarsal and intercuneiform or medial cuneiform in that location. A couple of pictures probably coming up will show you how that space is under tension. It's under constant tension in everyone right now. If you have the injury, it can stretch or separate that location. And I think we'll get maybe a few views of that in a few minutes. This is a tightrope procedure, which is a percutaneous method to repair that after complete reduction and restoration of that ligament. Typical treatment times for non-weight bearing for 4 to 6 weeks for ligament restoration and stability, and then ambulatory physical therapy. Ankle sprain is probably the more common and probably the most common sports injury, tear and stretching of the ligaments. Again, from the anatomy we saw earlier, the three main ligaments, anterior talar fib, calcaneal fib, and then posterior talar fib will be all included or one or the other. Talk about twisting injuries, instability of the ankle can develop if repetitive ankle injury occurs or a rupture of one of those ligaments can occur. But typically they're not, and bracing and physical therapy is one of the more common treatments after arrest, ice compress, and elevate conservative treatment. Again, most often they treated conservatively, but surgical need is there, and anterior drawer can be an indicator, which is a physical assessment per your doctor, or a what's called a Taylor tilt test. Usually indicates a tear of the anterior talar fib and or the calcaneal fib ligaments, which could be repaired if instability or chronic instability maintains. Location of swelling and redness, some ecchymosis on the bottom right, showing some swelling, very common post injury or symptoms of signs and symptoms of the posterior of a lateral ankle sprain. So the sprains occur. Other areas we look for also from ankle spraining, the ligaments, the fibula, and the fifth metatarsal, which is what we'll lead into next, which can also be assumed or the assumption will be the sprain, but it can turn into rotational injury causing the base of the fifth metatarsal to fracture. The more common fracture is the tuberosity, which is the red zone or the styloid, where the peroneal brevis tendon attaches in response to twisting your ankle. Mechanism for the tendon is if you stretch it, it pulls back. Therefore, it can pop that piece of bone off the end of the fifth metatarsal. Commonly, those are not treated. However, they can form instability or gap and go into non-union, which is a whole nother conversation, but they may require surgical fixation. In the purple there, you'll see an area which usually we operate on because it's an avascular form of the bone. That's where the nutrient artery comes in from the inside of the metatarsal. If that area is broken, it compromises the ability for the bone to heal. So we usually are a little bit more aggressive with that location and fixing the bone. So we don't have to deal with a delayed healing process or extreme non-weight bearing periods of time to see if it's going to heal, and then have to end up bone grafting and fixing that at a later date. You can see the same zones that show some other areas of the sites where stress fracture, Jones avulsion, and then avulsion, which is still considered Jones of the green and pink. The common location for the peroneal longus is right behind that pink zone where no fracture line is present between the fourth and fifth metatarsal. The proximal aspect of the fifth metatarsal, where you can have an os perineum. That's an accessory bone similar to your kneecap. Again, I made reference to that earlier, that can be visualized as a fracture, but it's actually an intratendinous bone that about 30% of the population has. Most of these fractures are, again, are non-operative and able to conservatively manage. Jones fractures, we are concerned about missing that Jones fracture, that Jones zone, again, because of the delayed recovery time. You'll see at the bottom here in the treatment, non-weight bearing cast 4 to 6 weeks, followed by 4 to 6 weeks in a cast, 75% heal with non-operative treatment. 30 to 50% will refracture another area that would re-injure. The second injury usually causes surgery to have to happen. So usually we're kind of preemptive. If we see a Jones fracture, try to fix it immediately. That way you can prevent any possible delayed non-union or repair at a later date. There's some x-rays here, very subtle fracture sign on the oblique view on the left side. You can see it through the base of the fifth metatarsal, and also in the what we call an AP film on the left side down on the fifth metatarsal is pretty visible there. There are times you can very vaguely see them. MRI is commonly utilized for pain in the region because of stress fracture. Now back to what we had made mention of earlier, is the Lisfrank's fracture dislocation is a common injury. It's an uncommon injury, not seen very often. When it is, it's a devastating type of an injury because it requires surgery almost always. And in major events can be life altering. changing activity levels to the foot, requiring multiple surgeries or fusions, etc. So 0.2% of all fractures, males, usually in the third decade, wide range of severity, combinations of, you see crushing, MVAs, falls and heights. But I've seen them as simple as stepping in a pothole, slipping in grass. And then there's the devastating, for example, the picture on the right where you have all the metatarsals that are involved. So subtle on the left where that line is in the intermetatarsal space, you'll see a gap between the metatarsal there. It's a very subtle x-ray that one must pay attention to, because if that's untreated, severe and advanced premature arthritic change will occur in 2 joints of that location, maybe even 3. On the right, of course, that's post-traumatic. That needs to be fixed right away. You'll see here on the dark red band of the anatomy picture on the right, that's the orientation of those fracture ligament. Base of the second metatarsal, intercuneiform joint, medial cuneiform. Injury causes separation of the 2 joints, and it causes midfoot instability, creating that arthritis. Refer to the location as all Lisfrank's areas between the tarsal-metatarsal ligaments, primarily as an easier method of describing the location, but primarily the Lisfrank's ligament is in that location. Dislocations occur when the ligament is torn. Okay. This area is suspended by soft tissue. You can see here the transverse ligaments connect the base of the 4 metatarsals as well, and there's no direct support. So this is an area of rotation that the ligaments just can't sustain during certain types of movements, like we'd said, falling or landing flat-footed from a height, and or rotational problem. Very subtle in some instances. That's why we always are concerned about certain types of presentations of weight-bearing injuries. Mild widening, which you can see, just a mild widening of, could be 1 to 2 millimeters, indicates a tear. Easy cheat sheets to do the contralateral film or the foot of the other side and compare to make sure you're anatomically wide in that location. So you can see this is a subtle opening on the right film versus the left, and that would need to be fixed. Flexible are not uncommon for this area. It does not change the outcome or the need for surgical care. It just proves that the ligament pops a piece of bone off or pulls a piece of bone off the second metatarsal. Very subtly on the x-ray in front of you, you can see down in the bottom of that first interspace, the V, there's a little tiny piece of wafer bone, and that shows that the insertion of the Lisfrank's ligament into the second metatarsal is pulled off. So again, that would need to be fixated. Clinical diagnosis, typically the patients will walk in the room, the foot will be profoundly swollen. Any pain over the midfoot with excessive swelling and pain in black and blue or ecchymotic. Presentation to the plantar aspect of the foot usually indicates an MRI need right away. You can try and get an MRI. You can try and get a weight-bearing x-ray. The patients usually are not able to tolerate the pain. I usually use the MRI because it will delineate the tear rupture, but it'll also show other fractures that may not be seen on plain film x-ray. Prompt referral and usually an urgent need for surgical intervention to maintain and provide non-weight-bearing established pre-operative care, and then leading to post-operative correction. Delayed in treatment. Well, Meg mentioned that earlier. It usually causes significant dysfunctional midfoot arthritis. Again, once we see that could or may have to be fused at a later date. When you catch Lisfrank's, as long as it's not what we call divergent, a significant divergent Lisfrank's fracture or dislocation, then then the repair can be established to some extent. And there are times where the fusion doesn't need to be completed. However, surgical reduction does. In some cases, again, it leads to chronic pain. But misdiagnosed or undiagnosed is definitely going to lead to that later arthritis that's going to show up. And this is our whole team: patient, surgeon, nurses, therapists, and anesthesia from a surgical perspective. Everything's not done. Certainly, we like to think we could accomplish all this by ourselves, but everybody around us has certainly helped us more than you could imagine, including getting patients just coming to the door. Getting patients in sometimes can be difficult, but this is kind of how the so-called circle of what we deal with on a daily basis is in front of you here. Looks like we're through with this kind of basic overview of what we do and see in a given day. If I know how to answer questions, I'll go ahead and kind of open the floor up to whomever may be watching.
Dr. Crosby, we have someone that's asked a question. It said, I was prescribed gabapentin for neuropathy. The pain is not improved and the prescription has expired. Can you suggest something else for me to mention to my podiatrist or see you on a next visit? Someone just asked that they are on gabapentin and their prescription has expired. What do you suggest them asking their podiatrist?
Am I still alive?
You are.
Okay. I guess a couple of questions. If you have neuropathy, if it's induced by diabetes or any other condition for that matter, if you take gabapentin, there are different medications you can take. I prescribe it in certain instances where, we may have nerve trauma after the surgical need for the things you see, like we have on have reviewed. When patients have it more systemically, certainly gabapentin, Neurontin, Lyrica, Cymbalta are many different medications you can take. If it's short-term use for nerve injury or nerve problem, then he or she should be able to refill that prescription as long as it's working. If it's something that's a variant, they may try a different medication. If you have other medications involved, in other words, if you take cardiovascular medication, blood pressure medication, et cetera, it's more of a medication side or medicines approach, then usually I'll defer to the family doctor from my standpoint to make sure there are no contraindications for the use of the medication based on what you're already taking. So there are a couple of different options. Neuropathy is a very difficult thing to treat because it's a nerve and a nerve response. You never know how the nerve is going to respond. So Neurontin can also, you can increase the dosing. That's another option, is change the medication, number one, if you can. Number two, increase the dosing to see if that dosing is going to help.
Another question that was just asked?
Where do I find that?
It's okay, I'll let you know what it is.
Okay.
Another question was, my daughter plays on a travel team. She stepped in a hole 3 weeks ago. She's hurting on the outside right of her foot. You discussed the fifth metatarsal. She's still having pain. Would you suggest her coming in to see you as soon as possible?
Okay. Yeah, so any inversion injury can start from the ankle where you have a fibular fracture. It could be the 3 ligaments we showed supporting the ankle and the lateral aspect of the ankle. It could also be the anterior process of the calcaneus, the bifurcate ligament, a tear of the tendon, or the fifth metatarsal. Fifth metatarsal is more common, ankle sprains, and then the fifth metatarsal. So A plain film x-ray, certainly at 3 weeks, we should see some improvement. If it was just a grade 1 sprain, usually ankle bracing and or, rest ice, compress, elevate, self-resolution should work. If she's continuing to have pain, I just suggest a basic plain film x-ray to rule out a fracture to make sure that she doesn't have a fracture or that she doesn't have an avulsion fracture of the base of the fifth or the anterior process of her calcaneus. So it'd be wise to bring patients in. Usually we say if an immediate sprain occurs, it's always kind of helpful just to get a set of films to make sure you don't have a fracture, and then you can rule out the obvious at that point. So I would suggest to everybody to come in with sprains and strains, just to make sure you don't have an injury that's prolonging the recovery.
Another question just came in, Dr. Crosby.
Mm-hmm.
Someone's son plays baseball, has severe shin splints.
Mm-hmm.
The lower leg is swelling quite a bit.
Mm-hmm.
Not sure what's going on with it. They've seen their athletic trainer. They're concerned with possibly compartment syndrome.
Mm-hmm.
Is that something they should address sooner than later?
Yeah, it's bilateral or one leg.
One leg.
Okay. Yeah, so that should be addressed immediately, I would say, if he's starting to have swelling of an extremity. The term tibial periostitis, a big word, just represents the same diagnosis as shin splints. Chronic and long-standing shin splints can actually create a tibial stress fracture. So that would be the biggest concern I would think about. Compartment syndrome, certainly another big issue, but more likely, I would say, if he's got chronic stress syndrome, that would be something we need to take a look at, because he could be running around on a stress fracture that may actually break, and that requires surgical fixation at that point. He should be seen immediately, if not basic film, maybe an MRI to clarify. Compartment syndromes usually one of two things. It's usually traumatically induced, which of course he's not, or it's exercise induced. And if he was a more consistent runner, and he may be, we'll have to kind of reevaluate, but if he's a more consistent runner, that's where you'll see compartment volumes increase. The only way to measure that's through, unfortunately, what's called a Stryker device to measure compartmental pressures. But to answer your question, I would say I would get him into at least a basic film x-ray, if not an MRI, to make sure he doesn't have a tibial stress fracture.
Two more questions for you.
Got it.
My daughter is on a competition gymnastics team. She is a level 4, which is one of the younger kids. Mm-hmm. Do you see younger kids with foot injuries?
Yes.
Are you located? Yes, no. That was. Are you located? Which offices are you located in, and are you able to get in quickly? Yes.
So I'm in 3 offices. I'm probably one of the more active travelers to locations within the group. I'm in Conway, at our office in Conway, right at the hospital. I am in Market Commons and in Murrells Inlet. And then from a surgical perspective, I cover Carolina Coast Surgery Center, Tidelands, Waccamaw, and Conway Hospital. In regards to getting in quickly, usually we have same-day appointments. A lot of times we may be full, but we'll get you in usually within the week. We try our best to get you in on same days if there's an urgent need.
And last thing, we just had someone from one of the high schools pop in and said, thank you for taking care of their son, that you thought it was a stress fracture. You got him back into playing his last game. Thank you very much.
Well, you're welcome.
Great job.
Thank you.